Hello, good evening, good morning, and good afternoon, dear vascular surgeon, hematology, and radiology doctors all over the universe. On behalf of the Egyptian Venous Forum, I am honored to welcome you all to the Russian-Egyptian Forum. It's a great chance to join our dear Russian vascular surgeons and share our experience, knowledge, and make it in a very nice platform, interactive with our colleagues from Egypt and dear friends from Russia, and introduce whatever you can enjoy. And it is a very good chance to ask dear attendees to share and interact with us. I'd like to thank Sigvaris Group for sponsoring this forum, and it is nice to start our work with MOH. This is very non-profit program sharing experience and education along the universe. Thank you, and I am honored to introduce my dear Professor Evgeny Shaydakov, the President of National College of Philology of Russia. Please, Professor Shaydakov. Unmute the voice, please, Professor Shaydakov. Unmute your voice.
Okay. Dear colleagues, dear friends, dear guests, on behalf of National College of Philology Russia, I would like to, but I'm sure that we continue in the nearest future.
Евгений Владимирович, вас не слышно. Не слышно.
And considerable progress. Хорошо. Сейчас слышно?
Сейчас слышно.
Да, сейчас слышно. С интернетом. Интернет тормозил.
Да, немножко тормозил. Dear guests, dear colleagues and friends, a rapid and considerable progress in phlebology during the past decades has formally joined specialist practice in almost all areas of medicine. Moving from the simple to complex, from basic concepts to brilliant ideas, we are getting absorbed by molecular and genetic mechanism of venous pathology. And the venous laser and radiofrequency ablation that emerged at the dawn of the 21st century to gracefully eliminate a pathological superficial reflux are complemented today by the foam, steam ablation, and novel glue-based techniques. Open thrombectomies, catheter direct thrombolysis, pharmacomechanical thrombolysis have been associated with the markedly improved outcomes in patients with an extensive acute DVT. Certain surgical approach of alleviate post-thrombotic syndrome, including percutaneous angioplasty and stenting of the iliofemoral segments, as well as restoration of the valvular function of deep veins, demonstrated promising long-term results. Do you think there is anything to unite all these methods? We told, of course, it's our friendship. I believe won't decrease from the truth by saying that it seems to be a rational conservative therapy at all steps of treatment, from symptoms alleviation to cutting-edge surgical technologies. Despite the obvious success, however, we often remain dissatisfied by the results. Dear friends, we try to include to our program the best presentation of our modern new presentation, modern new doctors from Russia and from Egypt. So enjoy our communication, enjoy our first Russian-Egypt Venous Forum.
Thank you, Professor Shaidakov, for this very nice introduction. Thank you. And very nice welcome speech. Now I am honored to introduce Professor Muhammad Al-Ma'adawi, Professor of Vascular Surgery, Cairo University. He's going to talk about venous stenting from theory to practice, single center experience.
Welcome everybody. Please turn to my shared screen. Yes, is it clear for everyone? Yes, I would like to thank the committee for their generous invitation to me today, and I hope I could be of value for every audience. We have to know something about the venous stenting, which should be summarized as follows in the few slides. The knowledge and the experience applied to the arteries cannot be translated to the vein because, as you know, the arteries are different, the veins in the structure, functions, and diameters, hemodynamics, as well as their response to the barotrauma. Also, we have fewer studies are done on the veins compared to those of the arteries, maybe due to reluctance of the surgeons to perform this research over there because somewhat to the fund and somewhat to they rely on the well-tested conservative treatments in the venous diseases. The ideal venous stent should offer us the following functions: it should convey the blood from the periphery to the heart and also balance the blood volume as it acts as a blood reservoir used in necessary, and also it balances the pressure within the organs as well. For that, the venous stent should be characterized by higher radial force than that of the arteries in order to compensate for the lower pressure from inside, in order to oppose the external pressure, both focal like in case of the May-Turner syndrome or in case of the global compression from outside by the fibrosis in the wall of the vein as a result of occlusion. Also, it should provide us with a higher flexibility and higher compliance in order to accommodate the changes in the vein diameter. As we know, there is doubling of the diameter of the axillary vein and the inferior vena cava during certain phases of respiration. To avoid the vein wall reactions by the rigid stent, this venous stent should be flexible as well in order to avoid the unexpected stenosis and or angulation that could develop between the stented vein segment and the unstented vein. A study examining the long-term results of the venous stents are unfortunately inconsistent, and many are irreconcilable and contradictory. A few results are waiting, and a few of them have been published up to now. Also, unfortunately, no FDA approval for any of the commercially available venous stents except recently the Bard Venova and the Veneti Vici stents. When we perform this venous stenting for the various causes, we usually use general anesthesia. This will be convenient to the patient, and also there is a recruitment of huge number of nerve endings that the pain of the vein dilatation could not be tolerated by the patient. Supine position serves us a lot because we usually, as I have said, many or more than one axis to accomplish our mission. Usually we use multiple excisions because it is better to have these multiple excisions before you give the patient full dose of anticoagulant. Also, it allows you to have a better crossing. Sometimes you cannot cross a lesion if you come from above, from the internal jugular vein, and the same lesion could be crossed if you come from the femoral vein. Also, it provides you with a contrast-free route map because it will define your target point you want to go to through the extensive collaterals, as we will see. Also, it provides you with the through and through, and its advantage will be elucidated later on. Here you can see this is coming from above, and this is coming from below. This one missed the target lesions, but our target lesions is on that way. Engagement, in order to engage in the affected parts, particularly if it is an occlusive part, you have to exploit the anatomical landmarks and respecting the anatomical variation, tolerating the extensive collaterals in which the wire tends to go. This is an example of the ascending lumbar vein. For the first glimpse at that, you may find that this wire had perforated the vein. Actually, it is not. If you can see the stump of this ascending lumbar vein, and it is more, the stump becomes bigger in next image, and this is after we realigned ourselves into the inferior vena cava. This is textbook illustrations of the ascending lumbar vein, how it looks in textbooks. Sometimes we do contrast angiography through the puncture needle and the parts of to cross our lesion. In that way, this is the wire goes into the intercostal vein and missed the site we want to go through. This is after the BTA and the correct position of our wire. Here is the crosses from one side to the other side, and in such instances we had gotten perforation inside this, but this is not troublesome because its effect is a puncture of a peripheral vein. Here is another illustration. We went through that site, and we go all through the internal mammary vein, and we found ourselves into the opposite side. This is called the substernal anastomosis, and I found it into the illustration of the textbooks. Unfortunately, this case, we couldn't cross the lesion in that patient. When it comes to the crossing the lesion, stenotic lesions are easiest to cross. Comes next is the acute thrombosis, which is easier to cross than the chronic obstruction, in which case the vein turns to be a fibrotic structure with microchannels only inside, if any. Here during the crossing, this part was difficult, and the other part is clear as we see. Also, we use the jugular femoral through and through wire because it gives you the registered rail mail in order to increase the pushability of your instrument across difficult lesions. Balloon angioplasty is performed by large diameter balloons at higher pressure than you use in the arteries. Sometimes we compensate for the unavailability of a big diameter balloon by applying the double balloon technique, putting side by side in order to dilate the lesions. Deploying the stent, usually we go from the normal to normal, and in cases of the multiple stent, usually we perform the overlap 1 centimeter or slightly more. Also found that the encroachment over the contralateral common iliac vein is somewhat safe. It is not absolutely safe, but it is somewhat safe. This is one of our cases as we deploy the stent, and this is the check angiogram. Should be performed after every step in order to see where you are. Unfortunately, contrast-induced nephropathy is low as compared to the artery, and nobody knows why. Low in the venous cases. This is the completion angiogram of the case before. This is the excessive dilatations here will involute over time, and it represents the. This is a case who was a male patient, 38 years old, developed left iliofemoral DVT before his presentation with venous ulcer resistant to heal. The DVT was provoked by surgery for varicose veins on the same limb. As for the detailed procedure, this is the scout angiogram through the common femoral vein. Yes, this is the iliac are occluded, and this is the corkscrew-like collateral vein conveying the blood from that side to the opposite side. This is another scout angiogram from above, denoting the presence of the exact site of the lesion. Again, our wire goes into the ascending lumbar vein and misses the target lesions, as you see here. We realign this wire into the correct passage that it should go through, as you see here. Let me repeat it again. Yes, this is IVC, and this is our catheter, which comes from above. Usually we should confirm the crossing of the lesion into the patent unaffected vessel, in such cases the inferior vena cava, and we found that we have successfully crossed the lesion, as you see. The balloon angioplasty comes from central to peripheral, as you see. Yes. Unfortunately, we got perforation of the vein here, as evidenced by the extravasation of the dye, as you see. This is extravasation of the dye. In such cases, we inflate a balloon there in order to tamponade the perforation, but here the inflated balloon missed the site of the perforation. It wasn't. It was ineffective. We repeated the procedure to make that everything is okay, and the balloon is effectively tamponading the site of the occlusion, as you see. And after we left it there for 5 minutes, we had performed check angiogram. It's clear there is no extravasation of the contrast material. That's to say, the perforation has been sealed. Deploy the stent, the central one first, followed by the peripheral one. And here the distal stent, making the overlap of 1 or slightly more than 1 centimeter, as you see. And this is the post dilatation. Here the completion angiogram after we free flow of the dye inside of the IVC. This dye came from below, not from above. This is the photo of the ulcer immediately after the procedure, and this is 2 weeks after the procedure with a marked improvement and a somewhat healthy granulation tissue. Thank you for your attention.
Thank you, Professor Muhammad. It was a very nice presentation, and thank you for keeping time. It was great. Now, I will ask Professor Alex Fuchsin, the Vice President of National College of Phlebology of Russia, to present his question.
Good afternoon, dear colleagues. Good afternoon for everyone. My question devotes to antithrombotic therapy after stenting. What medical remedies and duration of antithrombotic therapy?
Yes, some of the cases there is no arguments about giving them anticoagulant therapy who are patients suffering from thrombophilia. The patients other than the thrombophilic patients, there is a controversy about that. Usually we give this patient 3 months of full dose of anticoagulant followed by prophylactic dose for 2 years. The proponents for that is you want this venous stent to establish itself, and you want to guard yourself against the trauma you have inflicted during performing this stenting. We have no problems for this prolonged period of time of anticoagulants in such patients.
Thank you, and thank you very much for Mohammed for nice presentation.
Thank
very
you.
nice.
Thank you. Thank you.
Understand.
Please, Dr. Omar, do you have questions from the attendees?
Yes, we have quite a few questions. I will take one from them to Professor Ma'adawi. They said, thank you very much. It was a great presentation. In case of perforation, how can you handle this situation of extravasation other than long inflation of balloon over 5 minutes? What if this didn't work? What would you do next?
The next, you can repeat it once more. This is time, and during that period, you should check time in order to see if there is an excessive anticoagulation given to the patient. If after this repetition you find that there is still extravasation of the contrast material, you have no choice other than to put covered stent in such an instance.
Okay. Is there any experience of putting peripheral coil at the site of perforation, or have you faced this situation before?
Usually, I do not, and others do not use laterally coils in the veins because of the possibilities, high risk of central to make pulmonary embolism. They can implies to the lung. But if you want to, I don't do that. But if I want, I would recommend to make them made inside the stent. So I should put the stent first.
Okay, Professor Mohammed Ma'adawi, that's a great answer. Thank you very much. I think it is time now for the first poll.
Yes, thank you.
Okay, our first polling, Mr. Khalid. It's a very interesting poll, and I will pronounce it. How important applying compression stocking post-stenting? Is it highly important, medium importance, or low importance? So please submit your answer, and it usually takes 60 seconds to show the result. And the mic is back to you, Professor Ayman.
Thank you, Omar, and it was very nice. Till we have the answer of the polling, and I can introduce Professor Karl Lobastov, Bergov, Russian National Research Medical University, and he's a member of Council of National College of Phlebology of Russia. Professor Karl is going to speak about how to avoid post-thrombotic syndrome after deep venous thrombosis.
Thank you very much. Thank you very much, Professor Ayman. Colleagues, good evening.
Here, this is the answer. Omar, you can comment for the answer, please, before.
Yes, yes. The answer is very, very interesting. It showed that there is a high practice for using compression immediately after stenting, around 70% of that indeed. That is very, very interesting. Thank you very much, Professor Ayman.
Sorry for the interruption, Dr. Karl. Now you can start your great speech.
Thank you. I would like to discuss the prevention of the post-thrombotic syndrome. So the previous presentation was about the treatment of occlusions, post-thrombotic occlusion of the deep vein. And it is important to know if we can avoid this problem and avoid such complications that could be found after such interventions. So this is my disclosure, and we all know that the deep vein thrombosis, it is established incidence, and in Russia we have also some kind of official statistics. As you can see, it is accounted little bit more than the international data, about 1.5, 1.6 cases per 1,000 person years. And we know that post-thrombotic syndrome occurs in about half of the patients who developed proximal deep vein thrombosis, and it may be up to 90% of the patients who developed the iliac vein thrombosis. So it's really a very important medical and social problem, and it is essential to know how to avoid it. For the diagnosis of post-thrombotic syndrome, for today we use the Villalta score, and you know that it is a combination of 5 symptoms and 6 clinical signs, which are ranged from 0 to 3 scores, and the total amount of the score allows you to establish the post-thrombotic syndrome. However, it is very sensitive for the post-thrombotic syndrome, but the specificity is very low, and the recent studies show that the PTS could be misdiagnosed in about half of the patients. So if the patient had a pre-existing chronic venous disease, for example, varicose veins, some swelling, some pain in the leg, and he developed a deep vein thrombosis, and 6 months after, he also feels the same pain, the same edema, and the same varicose veins. But however, if you are calculating the Villalta score, you can classify this patient as having post-thrombotic syndrome. But however, it is not a post-thrombotic syndrome because it is the previous chronic venous disease that he had before this thrombosis. This is the main problem of the Villalta score, and however, we have no other established and verified instruments to diagnosis, classification, and assessing of the severity for the post-thrombotic syndrome. So for today, we know the several risk factors of the post-thrombotic syndrome and their influence on the risk of the developing of this disease is different. You can find the odds ratio for all these factors, and I will follow all these factors and try to find some evidence to removing these factors to avoid the post-thrombotic syndrome. So the first risk factor is the ipsilateral DVT recurrence. So it's the recurrence of the DVT on the same leg that was treated before. Of course, it is the most important risk factors, and if it appears, it increases the risk up to 10 times of the post-thrombotic syndrome. And there we can suggest 2 ways to avoid it. First, it is the surgical removal of the thrombus, because we have some very interesting data that if we make the good catheter thrombolysis or the good surgical thrombectomy or pharmacomechanical thrombolysis and remove more than 50% of all thrombus, the incidence of post-thrombotic syndrome will be only 5%. But if we are not able to remove more than 50% of the all thrombotic burden, in this situation, the incidence of post-thrombotic syndrome may be 50%. So it is 10 times higher, and of course trying to remove most part of the thrombus, especially from the proximal veins, from the iliac veins, it is essential to avoid the post-thrombotic syndrome. The other, I think it is the sequence of the developing recurrent DVT and the post-thrombotic syndrome. If you look at these two curves, you can find that they are really similar. So that the cumulative incidence of post-thrombotic syndrome increases with the increase of the recurrence of the deep vein thrombosis. And to avoid the DVT recurrence, we need to give to the patient adequate anticoagulation for the reasonable time. And the duration of anticoagulation is a very important issue. And here you can find the recent guidelines from the European Society of Cardiologists. And you can see that only venous thromboembolism that was provoked by the major reversible factor, like major trauma with plaster casts, like major surgery, only such kind of events need to be treated for 3 months, and after that you can stop the anticoagulation. All other situations you can prolong the anticoagulation treatment for more than 3 months to the identified time. So it is very important to give to the patient adequate anticoagulation for the reasonable time. The vein wall inflammation, it is the other part of the post-thrombotic syndrome, the migration of the leukocytes through the thrombus into the vein wall and providing some lesion of the vein wall. It's also lead to the structural changes and can reduce the venous wall tone as well as residual venous obstruction. It is also the factor for the development of PTS. And there we can find some drugs which are potential, which had the potential activity against the inflammatory process in the venous wall, and it may be statins and MPFF. And micronized purified flavonoid fraction, we studied it in one small pilot trial and find out that if the patient was treated with MPFF for 12 months in addition to rivaroxaban and compression stockings. In this situation, we can find the significant decrease in the incidence of post-thrombotic syndrome. You can see that it was only 13%, again 53%. And what is most important, it was the more complete and more fast recanalization of the deep veins, so the thrombotic burden was decreased better. And what is more important, it is the progression of the chronic venous disease, the transition of the lower CIP clinical class to the higher CIP clinical class was found only in 1 patient who was treated by MPFF and in 10 patients who were not treated with MPFF. So it's stopped the progression of the chronic venous disease, and maybe this criteria is more specific for the post-thrombotic syndrome than the Villalta score. The proximal localization of DVT is another risk factor, and there we can find only one method to remove it. It is a surgical thrombus removal, and we know the unfavorable results of the ATTRACT trial. Everybody knows it. It was not able to reduce the incidence of post-thrombotic syndrome, but however, the incidence of moderate to severe post-thrombotic syndrome was decreased in parallel with increase of the risk for major bleeding. But however, ATTRACT trial, it was not very good trial because the technical success was only 76%, and there was a low rate of the balloon angioplasty and very low rate of the venous stenting, the treatment of the underlying condition and the residual venous obstruction. And what is important, they included the patients with femoral popliteal deep vein thrombosis who may not benefit from the thrombolysis or pharmacomechanical thrombolysis. And the duration of the anticoagulation therapy was also not adequate. Most patients stopped their anticoagulation at 3 or 6 months, and there was a high rate of DVT recurrence, which also may be the reason for these unfavorable outcomes. However, the further meta-analysis, which included the results of the ATTRACT trial, they still shows us that the risk of PTS may be reduced by 35% by mechanical thrombectomy, pharmacomechanical thrombectomy, and catheter-directed thrombolysis. Age, it is the risk factor which we cannot influence. So unfortunately, obesity, you understand that it is a diet and physical exercises. And the pre-existing chronic venous disease may be controlled by the elastic compression. There is a very important role of the elastic compression. And we also had a not very good trial, the SOX trial, which was published in 2014. And it showed that there is no benefits of the elastic compression stockings, but however, there was also a very important methodological limitations, and the most important is that they started elastic compression very late, about at 1 week after randomization, and the patient did not receive any compression in the acute phase, in the phase of acute edema, and it was a very low compliance. About 70% of patients had used the compression stockings for 3 days a week and more. So it's not a treatment, it's just using the socks for 3 days a week. So it's not a very good compliance. But however, the more recent trials, they showed that elastic compression can prevent the post-thrombotic syndrome, and one of them, it is the ideal DVT study. It showed a very important issue that if you start the compression with the compression stocking, so with the compression bandage during the first week after the patient was admitted with deep vein thrombosis, you can reduce the most important symptoms of the post-thrombotic syndrome, like skin induration, hyperpigmentation, venectasia, and puff pain on cuff compression. So these components of the Villalta score. And it is really essential to start the compression stockings in the beginning of the disease, and this may be the key point for the preventing of PTS. The non-adequate anticoagulation, again, it is one of the problem, and it is related to the vitamin K antagonists, first of all, and the direct oral anticoagulants. For today, they can avoid such a problem, and we have some data that particularly rivaroxaban, when it was compared with the vitamin K antagonists, it showed the reduced risk of the post-thrombotic syndrome and improved recanalization of the deep veins, which allowed to avoid PTS. So we can prefer the dogs, particularly rivaroxaban, in such kind of patients. And the last thing, it is the residual venous obstruction. We need to remove all the residual thrombus if we make surgical thrombectomy. And that was also demonstrated in one trial by Anthony Camerota. He showed that if the residual thrombus was more than 50%, these patients had a higher risk of PTS development and the higher Villalta score compared with those who had a good lysis, a good removing of the all thrombotic masses from their veins. So in conclusion, I would like to summarize all this data and suggest that for iliofemoral DVT, we should prefer the effective, I would like to stress your attention that it should be effective catheter-directed thrombolysis, pharmacomechanical thrombolysis, or surgical thrombectomy. And we should always suggest the treating of the underlying lesion like residual venous obstruction and non-thrombotic venous obstruction. For the femoropopliteal DVT, we can make some enhanced therapy with the MPFF, for example, as we showed in our trial. And for any DVT, the early start of elastic compression stockings is essential. The using of direct oral anticoagulants over VKA, the long-term anticoagulation, and reducing of body weight if it is increased is also very important. Thank you for your attention, and I would like to answer your questions.
Thank you, Dr. Lobostov, for the very nice illustrated lecture, and thank you for keeping for time. Now I'm honored to announce Professor Ahmeduddin Hussein, Professor of Vascular Surgery in Shams University. Professor Ahmed, you can put your question, please.
Is my voice heard?
Yes, perfect.
Thank you, sir. Congratulations, Dr. Lobostov. It's a great presentation, and you have touched base on so many important issues. With your permission, Dr. Ayman, I have a tiny comment and then my question. The comment is that, as you nicely exposed, Dr. Kirill, different risk factors for developing post-thrombotic syndrome. I think one of the major points to avoid post-thrombotic syndrome is to have a high index of clinical suspicion, especially in case of non-resolution of symptoms following the first episode of DVT after 1 month. I hope you agree about that. Now my question is, who are the candidate patients for deep vein imaging? Supposedly you are having a patient with post-thrombotic syndrome and venous ulcer, which denotes an underlying not only reflux but also obstruction. So who are the candidate patients for deep vein imaging?
Thank you very much. So you mean imaging like CT angiography, MRI angiography?
Yes,
so
or MR venography, yes.
Yeah. Yeah.
I assume that these are also the same patients who are fulfilling the criteria for deep vein interventions.
Yeah, I agree with you that usually such additional imaging tests which provide us information on the iliac veins, they are essentially if we plan some kind of venous reconstruction. And of course, the patients with the progressive chronic venous insufficiency like trophic ulcers, like trophic skin changes, they need such investigations to find out the reason of these changes and to find out the opportunities to make some intervention to treat these lesions.
Thank you. Thank you very much.
Thank you.
Thank you, Professor Ahmed. Dr. Omar, do you have questions from the attendees?
Yes, we have a question. Thank you very much for a great lecture, Professor Kirill. He asked about, you recommended to use graduated compression stocking in PTS syndrome. Is there any specific indication of which degree of compression do you prefer? Is it 20 millimeter mercury 15, or what is the guideline for this? Is it grade 2, 3, or 4? What is the best from your experience?
Thank you very much. Yes, it's really very important because all the trials on the compression stockings in preventing PTS, they used the grade 3, so it is from 30 to 40 millimeters of mercury. So these stockings should be used in practice.
Excellent. And let me take this great opportunity to introduce a very dear brother and very eminent vascular surgeon, well known all over the world after such a successful webinar, my dearest Professor Ayman Fakhri. We got used to his good morning, good afternoon, and good evening over the last 6 months, and we enjoyed all his webinar. He is the president of the Egyptian Phlebology Society, which have actually been initiated 15 years ago. So he definitely have a vision that this Venous Society will be prosperous in 2020. He have a huge connection, especially with Russian colleague, because he spent a lot of his journeys between Russia and between Denis Borysk and a lot of his friends in the Russian society, and we welcome them all. And I would like to welcome our big star in Egypt, Professor Ayman Fakhri, for his great presentation, which is titled "The Microwave Ablation of Varicose Vein of the Lower Limb, Early Egyptian Result." And I will just announce that he is the first one to use microwave ablation in the Middle East. Professor Ayman.
Thank you, Professor Omar, for this very nice introduction. Thank you very much. Do you see my screen now?
Yes, we can see it very well.
Okay. As you said, I am going to discuss microwave ablation of varicose veins, early Egyptian experience. I don't have nothing to disclose. Incompetence of the saphenofemoral junction is the most common cause. About 70% of varices NICE guidelines recommended thermal ablation as the first line of treatment of varicose veins. Microwave ablation has all the advantages of radiofrequency ablation and latest laser fiber, and in addition, it does not become in contact with the vein wall, and it acts on the water within the cells of the vessel wall. The first case was performed on February 2019 by Marquetti in London, and we started our series only 6 months after him. The objective of our study today is providing the safety and the efficacy of microwave catheter ablation in treatment of varicose veins of the lower limb. We recruited 10 patients admitted to Royal Vascular Center from August 1st, 2019 to December 30, 2019 with primary varicose veins ranged from C2 to 5 of great saphenous vein. All were treated by microwave ablation of the great saphenous vein, duplex guided and using ambient amount of tumescent anesthesia. All patients had subjected to careful clinical exam, duplex evaluation, and signed their informed medical consent. The primary endpoint was anatomical and clinical success at 1 month follow-up, and the secondary endpoint are technical success. This is our machine. This is the echo generator of the microwave, and it is connected to the syringe pump of getting the tumescent anesthesia with just a pedal. And as you see, this is the catheter. This is the microwave catheter. It is very soft, malleable, and it goes easily through the vein. All patients treated by the microwave catheter, we go very close to the saphenofemoral junction using ambient amount of tumescent anesthesia. First of all, as we all did, we mark the patient and drap him, we insert the 7 French sheath, then introduce the microwave catheter with the duplex guidance. We came here, as you see, very close. This is the great saphenous, and this is the deep, and this is the femoral vein. We go very close to the saphenofemoral junction. And as you see, when we burn or start ablation of the vein, no forward propagation of the thermal wave. It is just down and backward. No forward propagation. So it is very safe to use it very close to the deep veins without fear of ablating or inducing venous thrombosis. Patient age was about 35.4 and male to female ratio was 6:4. The dominance was of the left lower limb. It is isolated left was on 6, 1 patient on the right, and both lower limbs in 3 patients. As you see, this is the measurement, and we got this is the measurement at the mid thigh, at the cuff region, and the ankle, and hopefully we got significant decrease in all measures after 1 month. It was significant decrease, and it was very nice. The great saphenous vein diameter was about, the mean was about 12 millimeter. It is somewhat a big vein, and the duration of flux was about 0.5 to 0.7 seconds. Again, this is our results immediate after ablation and 1 month later. We didn't get any resistance of reflux. We got 100% success, and the duration of the procedure was about 40 minutes. It is a quick procedure. The most important that patients returned to work after only 3 days, full active, and with the range from 2 to 5 days. Again, very important, the preoperative pain dropped from 9 to about 3. The preoperative pain dropped dramatically from 9 to 3. And venous clinical severity score also dropped from 10.7 to 7.6, which was significant. The take-home message regarding the technical tips, it is a quick procedure. It takes about 40 minutes. It is the same procedure. We can go very close to the to the femoral vein without fear of getting an injurious effect. And it is applicable technique. We did it in many patients, and the most important, we can use it in big veins. Patient preference, as you see, there was improvement in the preoperative pain and decrease in the venous clinical severity score. And it is cost effective as our patients went to their work within 3 days. To conclude, our dear friends, microwave catheter ablation is a safe and effective method in treatment of varicose veins with expected lower recurrence rate and fewer complications than laser or radiofrequency ablation of varicose vein. Before I leave, I want to invite you all to visit us in Luxor. Join us in AGVest 2020 from 10th to 13 December. Please come and join us. And this is our great monument. This represents the Russian-Egyptian friendship. It is present in Aswan, very close to the Haidan. Thank you, and I enjoy talking to you.
Okay, thank you very much, Professor Ayman. That was great, and thank you very much for sticking to time, because even if you take a long time, I wouldn't be able to do anything because you are the president of the Philology Society. And let me introduce one of the most eminent Russian philologists, Professor Elena Boleva. She is a member of the Council of the National College of Philology, Russia, and also a representative of the National College of Philology and a well-known name in philology research. If you like to ask any question to Professor Ayman, Professor Elena?
Yeah, colleagues, do you hear me? Yeah, here or not?
No, we can hear you very well, and we can see you very well too. You need to unmute yourself. Yes, we can hear you now.
Professor Fakri, thank you for your great lecture. And I have one question for you. It's known that endovascular procedure of veins are performed at different vein diameters, from 5 millimeters to 20 millimeters. And what's your opinion? What is optimal vein diameter for effective microwave ablation? And can we use this ablation for varicose tributaries of great saphenous vein without burn skin?
Okay, thank you. This is a very good question. And you touched a very important point. You're asking about the diameter of the vein, how it is effective in treating different diameter of the vein. Yes, you have a point. As you know, from laser and the radio frequency, there is somewhat limitation of vein. It is very effective up to 12 millimeter, 14 millimeter. After that, you can repeat the procedure 2 and 3 times. But using microwave, you can accommodate up to 25 millimeter diameter. It can work from just one ablation, as the microwave acts on the water within the cells of the vessel. So it can act dramatically on whatever the size of the vein up to 25 millimeter. But the best results achieved in treating vein from 6 to 14 millimeter. This is the best results.
Excellent. Thanks very much, Professor.
Thank you. Thank you.
Yes, and we have a question from one of the eminent vascular surgeons in Russia, Professor Alexei Nazikov. His question is very interesting. He said, what is the advantage of microwave over laser and the radio frequency? What is the benefit that this technique adds?
Yes. Thank you. This is a very nice procedure. Yes, it has 3 main advantages. Up to my little experience, it can act on bigger side of the vein safely. It can act on very close to the saphenofemoral junction safely. And it is a quick procedure because the catheter, the pull away the technique is faster. You don't want to make it half centimeter or half centimeter. It make it about 3 to 4 centimeter in one time. And you don't want to repeat the procedure. So the mean time to do the procedure from A to Z, it takes about 40 minutes.
Excellent. Thank you very much, Professor Ayman. You did put it in a nutshell. And it is time for the second poll. If I ask Mr. Khalid to put our second poll, which is very interesting poll, and we're eager to know the attendance. Now, post-DVT treatment, would you recommend the patient to put on compression for prophylaxis of post-thrombotic syndrome? If yes, for how long? So you have option number 1, no. Option number 2, 6 to 8 weeks. Or option number 3, 4 to 6 months. Please submit your question, and it will take around 45 seconds for assessing. And after that, we will show the result to everyone to show the Egyptian and Russian vascular philologists what do they feel about this. And I'm very interested to see how much percentage option number 3, which I think will be dominating. And the mic is back to you, Professor Ayman.
Thank you, Omar. Thank you very much. You can announce
right.
Yes.
I was right, 77% is option 3. And it will be interesting for candidates for 1 and 2, why they don't prolong the treatment, especially in post-DVT management. So Mike is back to you, Professor Ayman.
Thank you, Omar. And I am honored to introduce Dr. Roman Trojanski from International Institute of Healthcare and Additional Education Research Institute of Clinical Medicine. He's a member of National College of Philology of Russia. Dr. Roman is going to discuss cumulative reflux source, not a single vein. Please, Dr. Roman.
Thank you. Thank you for the introduction. Give me a sec. I share my presentation. Do you see my presentation now?
Yes.
Okay. Hello, everyone. I appreciate the organization committee for the invitation, and I'm excited to be here. Today, I want to discuss an interesting issue that might have seemed simple only at first glance. The issue is a source of venous reflux. It is my disclosure. Modern conception of reflux source includes several postulates. First, source of reflux is considered as a feeding vein located at the most proximal part of reflux conduit, and it could be saphenofemoral junction, pelvic veins, thigh perforating veins, etc. Second, an elimination of reflux source is a crucial and mandatory task of surgery that prevents a varicose vein recurrence. It's well known that in case of competent terminal valve, venous reflux is filled from some tributaries at the saphenofemoral junction area. But after high ligation with dissection and ligation the tributaries at the junction area, venous reflux does not disappear in the part of great saphenous vein located below. Zollman and co-authors surmised that in case of competent bath, terminal and preterminal valves, some tributaries located just beneath preterminal valves could feed venous reflux. In turn, our own experience tells us that if we want to track a feeding source carefully, we should follow upstream along the retrograde flow. However, sometimes a feeding vein could not be found at all, especially in early disease stages. And on the one hand, the studies and our own experience tell us that it might be, but on the other hand, the absence of feeding source contradicts to the energy and mass conservation laws. That is, it's physically impossible. Whenever I get this kind of dichotomy, I remember a quote of Brian Greene, who is a famous physicist. Human experience is often a misleading guide to the true nature of reality. In my perspective, it means that we don't have to blindly rely on our own experience because we don't see a whole picture. And only specially designed experiments could either approve or disapprove our guesses. Thereby, we decided to do the experimental study. We suggest that, we suppose that tributaries of great saphenous vein contributes to the reflux volume, and it can be in addition to the reflux from some incompetent sources. We aim to compare simultaneously measured reflux volume in the upper and lower great saphenous vein segments in the side. We performed prospective single-center experimental study. Patients who had an incompetence of only great saphenous vein with varicose vein presented only below knee level were included in the study. Initially, we measured a cross-section area of great saphenous vein at 2 points. The upper point was at 5 centimeters below saphenofemoral junction. The distal point was 5 centimeters above knee level. Then, we carefully measured a cross-section area of each tributary joined to great saphenous vein between the points of measurement. Then, we took a measurement of reflux flow parameters, such as time average linear velocity and reflux time at both points simultaneously by 2 researchers and 2 identical ultrasound machines. We used the distal cuff compression decompression as a provoking maneuver. Finally, we calculated a total cross-section area of all the tributaries located between points as an arithmetic sum. Reflux volume was calculated for each point. Then we estimated the difference in absolute values of reflux volume and its relative changing. Okay, let's take a look at the results. There was no difference in cross-section area between the upper and lower points. Meanwhile, reflux volume was significantly higher in the lower point. We know that volume of flow is a product of area, velocity, and time. So the difference in volume of flow could be due to the difference in either area or velocity or time. Since the cross-section area and reflux time were almost equal at both points, the difference in reflux volume was owing to the difference in time average velocity. Moreover, time average velocity was the most impacting factor on delta reflux volume. The absolute value of delta reflux volume was almost 8 milliliters, and its relative changing was 65%. There were only competent tributaries between the points, and their total cross-section area was 2 times less than cross-section area of great saphenous vein itself. So we can do the following conclusions. Reflux volume increases caudally from along great saphenous vein inner side. Second, the increment of reflux volume in a distal direction is the result of inflow from competent tributaries. So the so-called Venturi effect could be at the root of the study results. Let's reflect on it. During the reflux, average velocity of retrograde flow is considerably higher than average velocity in any of the tributaries. Given the energy conservation law, we know if a velocity increases, a static pressure decreases. Hence, the static pressure in great saphenous vein is less than static pressure in any of the tributaries. Therefore, blood shifts into great saphenous vein from the branches. As I mentioned above, we don't see this whole picture because of the ultrasound examination is usually performed by a single practitioner with one probe only, and in particular part of reflex conduit during a provoking maneuver. And if we want to see the whole picture, we should be like Shiva. The tributaries located between points was the reason for considerable reflex volume increasing. We got an additional 8 milliliters of blood from their total cross-section area of 0.16 square centimeters. In turn, 13 milliliters of blood passed through the upper point, but there are several constant tributaries above this point as well. And the total cross-section area of them was 0.25 square centimeters in the study. So we can surmise that significant part of these 13 milliliters of blood was received from these tributaries, and that sapheno-femoral junction gave even less than this amount of blood. A total cross-section area of all the tributaries located between the junction and the lower point was significantly higher than a cross-section area of great saphenous vein itself. We suppose that the major part of reflux volume comes from the tributaries and not from the junction only. It was confirmed when we stratified the sample into two groups. The first group, it was incompetent ostial valve. The second group was competent ostial valve, including 37 and 33 lower limbs respectively. Delta reflux volume was significantly higher in the first group, despite the fact that a total cross-section area of the tributaries between points was equal. Again, the reason was because time average velocity was significantly higher in the first group. So, as a discussion, we offer to consider a reflux source as an aggregate of all feeding veins joined with reflux conduit, either competent or incompetent, instead of considering only certain veins as the source. And it is technically impossible to eliminate all of these feeding veins. In most of the cases, we eliminate reflux conduit only. Moreover, all of these feeding veins exist all the time. And before the reflux emerges, these veins add blood volume for anterograde flow only and become the source just after reflux arises. And we guess that varicose vein recurrence should be just a matter of new reflux conduit emerging, and it's not as a reason of not eliminated reflux source previously. Dear colleagues, let me finish with another great physicist who said, the great enemy of knowledge is not ignorance, it is illusion of knowledge. Thank you for your attention.
Thank you, Dr. Trojanetsky. Congratulations for this very interesting and very well organized talk. It was great. It is a very nice piece of work. Now I ask Dr. Professor Khalid Al-Kaffas, Professor of Radiology and Interventional Radiology, Cairo University, to ask his question and comment. Please, Dr. Khalid.
Hello, everybody. I will thank you first, dear Dr. Roman, for your very marvelous and nice presentation. I think you have tackled and overlooked areas of patients suffering from varicose veins regarding the diagnosis of the reflux sources. I want to ask about two questions. The first of all, do you use this information you gathered from your presentation to guide you to avoid ablation of the great saphenous vein or removing the great saphenous vein as a treatment of patients suffering from truncal varicosities, because if you have, in my opinion, if you ablate the great saphenous vein, you'll abolish all the predicted refluxing sources regarding this. My second question, from the diagnostic point of view, is the sonographer have to guided by the patient's manifestations or presentation to perform his ultrasound examination of the patient, or only follow the standard protocol in examination of the patient? Thank you.
Thank you for your questions. Excellent questions. First of all, I think yes, the good idea, maybe the main procedure that we have to do is eliminate reflux, the trunk and varicose tributaries. It's a good idea, but maybe it's a little bit complicated, and we don't have any time to discuss Chiva and so on. But anyway, to eliminate all of reflux conduit, it's a good idea. And it may be, I sure that it is a best what we have at the moment. The second, I didn't hear exactly what do you ask?
I'm asking about during performing the ultrasound examination of the patient suffering from varicose vein. Do you follow a standard protocol in the examination, or you are guided by the presentation of the patient? If the patient is presenting by extra axial varicosities only, or varicose related to the trunk?
Okay, thank you for your questions. Usually, I guide it for the recommendation, but in usually practice, I should restrict the amount of mind that I to do the examination, and usually I try to discover the saphenofemoral junction, distal part in the thigh, and distal part in the calf, and what we have all of the trunk, incompetent trunk, or we have only segment reflux of this reflux conduit.
Okay. Thank you very much.
Thank you.
Dr. Roman, I think you have some questions for Dr. Roman.
Yes, we have two interesting opposing questions. The first one from Professor Alexei Nadvikov. He said, according to your data, it does not make sense to perform Shiva procedure in a classic version. And the other question from Professor Hosvip Manjikin, he said, your hypothesis is killing Shiva technique. So what do you answer for this?
First of all, I would prefer that it is not hypothesis, because we did a measurement, and this measurement was statistically significant, and we have strong physical explanation what we saw and what we see in the patient. About Chiva, it is more complicated questions, and I think no, our data doesn't kill the Shiva methodics, and I would prefer to say to this way that Shiva method it is a good method when we don't have advanced stages of the disease. I would prefer this way at the moment. Another explanation, if I would want to explain in the physical point of view, I think it would be a little bit complicated. It needs more time.
Thank you very much.
Okay, thank you, Roman. And now it is my turn to introduce my dear friend and my great fellow, and as I always describe him, my safety net. I would like to introduce Professor Muhammad Omar Farouk. He's a senior consultant of vascular surgery in General Organization of Teaching Hospital and Institutes, Cairo, Egypt. Professor Omar, after he was graduated from Shams University, he extended his training in West Midland vascular rotation in the United Kingdom and got his fellowship from the Royal College of England. Dr. Omar has a vast experience in surgery, of course, and in vascular techniques, especially in EVAR and complicated cases of EVAR. We shared a lot of educational programs, and we start our work together, let's say, more than 15 years ago. He's doing a very good job in teaching and in all modalities, and he is a leader of the Egyptian Fellowship Program, and he is also examiner of the Royal College of Surgeons. Today he is going to discuss different modalities of exolaser in the treatment of telangiectasia.
Thank you very much for the nice introduction, my dear Professor Ayman, and I will promise I will stick to time. I am very much honored by having such a Russian philologist as an audience for my lecture, because I'm very fascinated and interested with the advances in Russian medicine. So my topic is different modality of exolaser treatment of telangiectasia, and I promise you my presentation is extremely simple, as not complicated. So my learning objective is to demonstrate how to use laser for veins, what is the advantage and disadvantage of each technique. I will summarize just my experience, and I will put tips and tricks that I have collected over the last 25 years. So definition, we know that laser is an amplification of a stimulated emission of radiation. We know telangiectasia, this is the picture that we see, which is dilatation of subpapillary plexus up to 3 or 4 millimeter. Diagnosis, essential that you should have a history, you should have thorough examination, you should have a duplex scan. I prefer to do it by the operator. And there are two machines, which is augmented reality and vein viewer, which I think is mandatory before treating telangiectasia. If you don't have them, I wouldn't advise, because just giving laser to veins that you can see will not give you a good result. So this is very important. And the photo documentation is essential. You must use DSLR camera, not any camera, not just a mobile. You must have a standard light. I prefer to have a cloud storage, and I prefer to use Adobe Lightroom for software analysis of the result. Why this is important? Because it makes a big difference. If the patient have seen what his veins looks like in 3 or 4 months ago, because he forget this, and this in all patients, his response will be quite different. And this is one of the nice articles to show, if you don't show them how the picture was, you don't get patient satisfaction. So imaging is not a luxury, it's an essential. I use this kind of grading of combination of varicose vein and telangiectasia. We have from 1, which is easiest, to the most difficult, which is 9. Each one you must have a strategy. This is one of the units in Cairo. I was able to convince the hospital manager to buy 5 types of laser. All of them were profitable. I bought CO2, Nd:YAG, KTP, diode, and the argon laser in just 1 unit. And this is quite a big expensive, especially for a private hospital in Cairo. Now, I wouldn't go into basics of laser physiology, but I would just describe that you must need a little bit of basics of your tool. So you must know the penetration of your laser. That is why one of my best tools is Nd:YAG. You also have to know diode, carbon dioxide, and KTP, and you must know what type of penetration you will get from it. Now, the theoretical advantage over sclerotherapy, any sclerotherapy will get extravasation of arteries, which makes a little bit of discoloration. You wouldn't get this of laser. Laser have an added value of skin rejuvenation and suppression of inflammation, which you wouldn't get with the sclerotherapy. So it's a different tool than sclerotherapy. The types of laser I would advise you to select from with vascular indication is CO2, argon, Nd:YAG, KTP, copper bromide, and a flash lamp pulse dyed laser. I prefer the Nd:YAG and KTP combination. This is my personal preference. I will summarize to you over the next 5 minutes my experience in a nutshell over 10 points that took me 25 years to know. The first point is each type of laser, you must adjust your parameter. So whenever you buy a new laser machine, like buying a new Ferrari, don't drive it the first time with a high speed. Know what is your tools, what is your parameter. At least it takes a month. This is important first step. Secondly, always picture the laser and start by test run. Don't start your first parameter right away. Get lesion, you select to specify, and get 2 or 3 parameters and review the result in a couple of weeks' time. You will be surprised how different change in parameters can give you different results. So don't decide before this first test. Now, I use cooling. I think it's a fascinating tool, and we use this kind of gloves filled with colored ice water to give different color. We give it half an hour before laser. I think it's a good idea. If the patient doesn't feel pain, it will usually come again. Now, I have discovered that I usually classify the veins into type 1, 2, 3 according to diameter, and type 4 if you have lipodermatosclerosis. Well, you need to use the highest fluency to give you a better result. And vein reflux does not affect your result if you have a small vein like type 1. It affects you when you have a bigger vein like type 3. And this is very important for your management. Try to select the type 1 in your patient to get a good result first and then get more sessions. Best widely used laser is Nd:YAG, and there are different modes of Nd:YAG, and you can buy Nd:YAG KTP combination in one laser machine. Number 6, as an advice, lipodermatosclerosis, in 60% of my patients, exolaser have beneficial effect. It comes after 2 months duration, and this is one of the diseases that you don't really have much to offer other than skin care and antibiotic. So laser here have a unique advantage. Now, your best time in getting the result is after 3 months. So you must be very clear to tell the patient that the result will be after 3 months, and I will show you the image. Because by the time 3 months, you will get used to her leg getting better, she wouldn't realize the difference. So this is an important, 3 months is the key. Artificial or augmented reality, I think it's an essential tool if you are going to use laser, because it will tell you the feeder vessel. If you cannot decide where is the feeder vessel and close it with laser, you will not have a good result. Now, number 9, always lower the patient expectation. Any patient comes to me usually having in her mind, not just the legs are getting better, but she will come a beauty queen after having laser. Unless you put a realistic estimate of the result of the laser, usually you run into trouble, and this is very important. Now, the last lesson that I have learned is that not every patient is suitable for laser. So my conclusion is transdermal laser is very powerful tool to a phlebologist. It has an FDA approval since 1998, and I would like to say thank you for all the Russian colleagues. That is why this is not my handwriting. This is PowerPoint handwriting in Russian to say thank you. And I've tried to get a voice translation in Russian over your screen. I hope it did work. And thank you very much for your time. And thank you, Professor Ayman.
Thank you, Dr. Omar. It was very nice, illustrative and conclusive talk, summarizing all the benefits of exolaser.
I'm ready for butchering by question.
Yes, I think you will get many. Let us start by Dr. Sergey Blatsov. He's a member of Council of National College of Phlebology of Russia. Please, Dr. Blatsov.
Hi to all. I would like to congratulate you with a nice presentation, excellent experience. And what about laser skin burns? One of the most unpleasant complications of the laser skin burns. How often did you meet this complication?
Can you say that again? The complication, which one? Hypopigmentation, hyperpigmentation, which one?
Skin burns.
Skin burn.
The trauma.
Yes, yes, that's a very good question. Actually, the new laser machine is non-charring laser, which is laser that you cannot burn the skin with. I think the charring happens when you are using too much laser in your first session as a treatment without testing. I use cooling. I test the vein after few minutes, and I start with the lowest fluency possible. It happened in my first 5 years. I usually get burn in about 1% of my patients as a laser burn. I haven't seen it in the last 20 years because of this technique. Good cooling, start with the lowest parameter of laser, assess after a couple of weeks and decide what to do. I haven't seen it in 20 years, but now you can actually purchase laser which is called non-charring laser, which means laser that could never burn the skin because it gives you a feedback immediately and lower the result of the beam of the laser. But it's a very nice question.
Thank you very much.
Dr. Robert, I think we have many questions.
I will take the question, Professor Ayman, don't worry.
Okay, I'll get one from Dr. Sohail Naguib. He is asking about using the virtual light and then viewer.
Yes.
When using them, you can see reticular veins. Do you use sclerotherapy before doing laser, or you ablate both using laser?
Yes, I know that you are a big fan of CLACS technique, Professor Ayman, and I know you have very good result with the sclerotherapy. I am not a fan of the sclerotherapy. I'm a big fan of laser. Let us say 90% of my patients with telangiectasia up to 3 millimeter, I usually get a good result with laser alone. But I am started to be open to CLACS technique. I hopefully will start it soon. And sclerotherapy, in good hands, with good experience, can add to the value of laser.
Okay, you answered the second question. This is a question from dear friend from Domyat asking about, do you think laser add much to sclerotherapy?
Yes, I think, yes, that's a very good question. I think laser is different ball game. Number one, you don't get extravasation. Number two, you don't have the needle phobia people are complaining from. Number three, you don't get the amount of intravessel thrombosis with sclerotherapy if you don't evacuate the blood. Number 4 and 5, there are two beauty about laser beam, which is give you a skin rejuvenation, which is what the plastic surgeon use for the face, and it actually reduce inflammation. So laser offer a lot more than sclerotherapy. I wouldn't say sclerotherapy is not good. In good hands with good experience, you can get a good result. And I'm very interested in the new technique, which I haven't tried, CLACS. I hopefully try it after you, Professor Ayman. But laser is different ball game.
Thank you, good answer. Now I think this is the time for the third polling.
Yes, third polling, please. Mr. Khalid. And thank you very much, Professor Dennis Borsk. It was your idea and it was a great idea. So the polling, the third polling, post-microwave ablation, which type of compression you would apply for better compliance and patient? Bandage is sufficient, graduated compression, garment, no need to apply any compression. Again, very interesting question, and we'll see our dear Egyptian and Russian philologists with their answer. And the mic is back to you, Professor Ayman.
Thank you, Omar. And now it's my turn to introduce my dear friend, Denis Proska from Russia. And he is the real man for putting this forum to become a real. It was his idea, and I like it very much. It was great to share our experience. Professor Denis is working in the clinic of phlebology and laser surgery, and the chairman of control commission of the National College of Phlebology of Russia. He is going to discuss retrospective study of neurological damage of after endovenous laser ablation. Please, Doctor, before we start, Dr. Omar, you can announce the result of the polling for Denis start his talk.
Yes, the result of the polling was very interesting. The option number 2, graduated garment, was more than 50%, which is quite expected. It was very interesting polling. Thank you very much, Professor Ayman.
Thank you. And now the mic is yours, Denis.
Okay, do you see my screen?
Not yet.
Okay. Okay, sorry. And now?
Yes.
Okay. So here it is.
Yes,
so
great.
thank you, dear colleagues. Yes, my presentation will be about our retrospective study of neurological damage of saphenous nerves after endovenous laser ablation. It was done with my teacher and my professor Alexey Fokin, who is also here with us, and also with our student Maria Shaldina. She is very active. And you know, I'm really proud of this study because it was very easy, but gave us a lot of interesting information. I will show you. But before I start, I want to show you my experience. So it was in 2017. It's our picture with Ayman, with this monument of friendship between our countries. And I also had the first experience of sailing. It was really like this picture, you know. I was sailing with the male, and it was fantastic experience, and thank you for this. So before I start, I want to show also this picture. It's interact nervous system extracted by 2 medical students in 1925. And as I told you, we also have done this study with our student. So the frequency of the saphenous nerve injuries, it's very different data about it. So from 0 to 65% with the stripping, and from 0.7 to 36% with endovenous laser of GSV. And several studies investigate this problem, this issue, but it's not clear how often interventions lead to decrease of quality of life, especially after endovenous procedures. Studies have focused separately on active patient compliance, a sharp decrease of quality of life due to this compliance, and also to instrumental assessment on the neurological examination. The aim of our study was to investigate the incidence of symptoms of the saphenous nerve damage after laser of GSV, as well as to determine the influence of these symptoms of patients' quality of life. It was a retrospective single-center study. Approximately 120 patients was there, and 151 isolated lasers of GSV without microphlebectomy or sclerotherapy. So here is, so about 36% was men, and around approximately 65% were women. Here is our laser settings. We use 1470 nanometers laser, tumescent anesthesia, automatic pullback traction, needle, 12 centimeters needles, and single ring radial fibers. Average length of veins was 45 centimeters, and the amount of anesthetic about 380 milliliters. So, and average volume of anesthetic per centimeter was approximately 8.5. I need to describe you, explain you our energy settings. This patient was already in another prospective study of different settings of laser regimes for endovenous laser obliteration. So, and here you can see these settings. And from our previous study, we know that in this 5-watt group, we have less damage of venous wall. In 7-watt, bigger, and the biggest damage of venous wall we had in 10-watt group. It's quite important. I will explain you later. So we could compare these 3 groups between each other. But in the venous linear damage, linear density was approximately 70 joule per centimeter in all of these groups. So here is distribution of patients by puncture level. Most of them was on upper calf or in the mid calf. And here, I think you don't see, but total at thigh level, it was 25%, and in calf level also about 75%. Here is our survey for patients. So our student called them, made a phone call and asked them this survey. This survey was completed with our neurologist. So we asked about different feelings of patients, and which was which can give us some information, could give us some information about neurological damage. And also we asked about duration of symptoms, about localizations, and also quality of life. And we had only one important question: do these feelings interfere with your life, or do you feel them only when touched and they do not bother you? So it is very important. Here is distribution of our of that symptoms, and you can see that in 61 cases we had some feelings of nerve injuries. So it's approximately 40%. It's quite a lot, big number, but decreasing of quality of life was only in 4.6%. So very, very small amount. It's only 1 of 20 patients has had this decreasing of quality of life. All of other patients just had these symptoms when they touch their skin, you know, or somewhere wear their clothes or something like this. So in majority of cases, there was no any interference of their life. So, okay, here is the results. And so here is the total, sorry, I will close this. So decreasing of quality of life, total, and so it's a total symptoms and decreasing of quality of life. But as I told you, it was a retrospective study. We called patients in February, you know, and patients was operated from February, which was built before this, so for 1 year. So it means that in time of the call, we had so symptoms disappear in majority of patients. Okay. So yes, median of the symptoms relief was approximately 2 months. Here is localizations of symptoms. 13.9% was on the thigh. Sorry, I just a second. Sorry for this. Here is localization of symptoms. 13.9% on the thigh, 7% close to the knee, and 30%, approximately 30% were on the calf. 7.9% of patients had symptoms in 2 or more localizations. And here is the result. The analysis of puncture level in different parts of thigh or calf didn't show any significant association with damage to saphenous nerves. What does it mean? The symptoms appeared at the same, so on the upper calf or on the lowest calf was exactly the same, or in the middle calf. It's not important where do you make a puncture, on the upper calf or on the middle calf. It's more important where you do this, on the thigh or on the calf, because puncture on the thigh will give you less nerve injuries. So, and the puncture below the knee significantly increases the risk of nerve injury. There were no statistical significant difference depending on the power. As I told you, in that 3 groups, we know that we have different vein wall damage, but we didn't find difference between these 3 groups with different settings with the neurological damage. And so groups were with different energy parameters were comparable in a level of puncture of GSV. It's important. And there was no significant relationship between level of puncture on the thigh or calf and the effect of the symptoms or the patient's quality of life. As I told you, it's not important where you do on upper calf, on the mid calf. It's more important the thigh or calf level. It will give you difference. From aortocoronary bypass, all of us know that saphenous nerve is going close to the great saphenous vein on the calf. And this is an explanation of our findings, of our results. So no significant correlation of puncture level in different parts of thigh and calf was found in relation with nerve damage, as I told you before. Significant difference between puncture of thigh or calf was present. And no relationship between puncture level and the effect of symptoms of quality of life. So it was the same in all of the, so it was the same. It, again, in the mid calf or upper calf, and it was better results in the thigh. And I want to explain you also, it is one of the last slide of my slide. So heat damage, what can be a reason of nerve damage? Heat damage, high temperature change with 5 watts. So we found that it was the same damage in 3 energy settings. What does it mean? That 5 watt could be enough for damage of surrounding nerves. That is why we had similar neurological damage in all of these 3 groups. Maybe we cannot know this exactly. Tumescent anesthesia, so we can have a neurological damage with manipulation of needle during tumescence. It's also possible. And perivenous inflammation after EVLA, it also could be a reason. We don't exactly know. So here is the 3 reasons, 3 mechanisms, which all of them could can give us this neurological damage. So advantages of our study. And the venous laser was not combined with microphlebectomy or sclerotherapy. We received very valuable information, the feelings of the operating patients, their relationship of these symptoms. It's more important as neurological investigation, I suppose, because we can find with neurological investigation some damage, but what for? The main idea for us is what is the feelings of our patients. We are treating patients not as we told, yes, like ultrasound picture or something else. Or so we're interested of their feelings. It's more important for us. And patients were interviewed by an independent person. I didn't ask patients with this survey. My student asked them. As you know, if I asked that patients, I would maybe ask them another questions to, to reduce the amount of neurological damage. But it's independent person who did this survey, and it's very important for our results. And disadvantage, it was a retrospective study, and it was remote survey by phone. Yes, it's disadvantages, but anyway, I think that it was very easy study and gives us very interesting information, and also for me as for surgeon who did all of that 150 procedures. Conclusion. Symptoms of the saphenous nerves damage after endovenous laser of GSV may occur in 40%, but only 4.6% of cases these symptoms reduced quality of life. And moreover, most of them disappeared in approximately 2 months. Puncture below the knee increases the risk of saphenous nerve damage. Yes, but after our data analysis, we can recommend endovenous laser, and also we can recommend the puncture level below the knee, because as I told you, most of these symptoms were not so important for patients, and that symptoms which decreased quality of life, all of them disappeared or at least become less. So, and not any serious compliance of patients with it we never had, in spite of just one case of patient with diabetes, and it's only one case for 7,500 of procedures. And it is not in this study. Thank you for attention.
Thank you, Dennis. It is very nice presentation and very nice study. Me myself, I think I have to revise my technique. I really get a lot of experience. I'll ask you to make another study together. Let's do it for small saphenous vein ablation. I think we can get more data regarding the small saphenous. Let's think about it. Now I'll ask Professor Amr Abdelrahim, Professor of Vascular Surgery from Cairo University. He is going to comment and ask his question. Please, Dr. Amr. Unmute your voice, Dr. Amr.
Oh, sorry. Thank you, Professor Ayman and Professor Romer, for this nice meeting. And it's a very good presentation about the nerve damage during the endovenous laser ablation. So to summarize that, the problem with the nerve injury is related to the puncture site and below the knee and the tumescent anesthesia beside the thermal injury itself. What about the duplex machine, the resolution of the duplex machine to a little bit delineate or show up the site of the nerve itself, so that we can try to avoid by duplex guidance to avoid this injury. So if it can be can add to this study, or can be used as a tool to prevent nerve injury. This is the first question. The second question, to recommend doing the laser at the knee level or above and not below the knee, because although the quality of life does not doesn't change that much, but still bothering the patient, and the patient comes to our clinics and say, "Oh, I have it's a very unpleasant sensation, and I want to have my normal sensation back." Although it doesn't affect his quality of life, but I think it's a bothering problem. So can be like a rule to avoid putting the needle below the knee level. Thank you.
Thank you for your very important question. So to be honest, I saw many times of presentations with imagination of saphenous nerve with ultrasound, but to be honest, in my practice, I do a lot of procedures, and I think it's quite complicated to visualize this saphenous nerve every time. You know, sometimes it's possible to see it very easy, but you know, in majority of cases, I think it's quite complicated to try to visualize this nerve. You know, in my practice, we treat a lot of patients, you know, every day about 10 patients, and it's like, you know, I think it's very difficult and complicated. But if you can visualize, of course, it's a good opportunity, and you can improve your results. And so if it's possible with your ultrasound machine, if you're well experienced, of course you need to do this. But it's quite difficult to do in everyday practice, in my opinion. So having said about puncture level, yes, I agree with you. Sometimes it's not a good feelings, but as I told you, in our survey, only 1 of 20 patients had really not a good feelings, you know, a decreasing of quality of life, and these feelings disappeared with time. Also, I want to tell you that in our hemodynamic opinion, we think that it's better to make ablation from below the knee, because in majority of cases, reflux starts from above the knee and finishes below the knee. That is why we try to ablate the whole GSV from STS to below the knee level. But of course, if you have a lot of complications, you can do a sclerotherapy of the you know, or make just follow up with this patient. So it's your choice, you know. In my practice, I think so. It's reasonable to ablate the knee, the saphenous vein from below the knee. Okay, I always try to do it from the upper calf. But as I show you, it's not important difference between upper or mid calf. Anyway, you can have the same complication rate.
Thank you, Dennis. Dr. Omar, you have a question from the attendees?
Yes, we have very good question. Thank you very much, Professor Dennis, for such a great lecture. Question from Dr. Muhammad Haggag. He said, why you depend on subjective tool like pain and the quality of life rather than nerve study or correlation of both?
I beg your pardon. Can you repeat this?
I repeat the question again, yes. He's asking why you depend on subjective tools like pain and the quality of life rather than a measurable tool of nerve conduction study or combination of both.
Unfortunately, is it written on the? Is it written?
It's written,
okay,
yes.
Dennis, he's asking why do you use a subjective method in studying the nerve injury rather than objective method like nerve conduction?
Okay, because it was just a simple idea. So my student came to me, it's a student from our department, you know, he came to me and asked, what can I investigate? What can I investigate? And I had this idea. It was very simple study. It's just a phone call to patients and ask their feelings. We made this survey and did this study. At the end, I suppose that we have very important data of the feelings of our patient. To make another measurement, we need to organize prospective study with neurological assessment, and you know, so it's difficult to organize. But this investigation was organized in a few minutes, and that is why I'm proud of this investigation. You know, it was just a very easy idea. That's it, and all of us can have this. Quite, I suppose that it's quite interesting data. You know, because it's more important than investigations of neurological assessment. It's feelings of our patient.
Okay, thank you very much. And the mic is back to you, Professor Ayman.
Thank you, Omar. And I think now we have some time for discussion. And I think we have to give the chance for speakers if they have comment for other speakers. We have some great speakers and some great panelists. The panelists ask now, it's time for speakers to ask. I may ask Professor Lobastov if he has a question or comment for any of the speakers.
Thank you very much, Professor Reimann. I would like to comment on the last topic presented by Denise Borsuk, because nerve injury is really a very important question. But however, there is one question in chat that this damage is irreversible and how can we screwify the patients and something like this. But however, all these, most of these lesions, they are reversible, and actually it is not just a lesion of nerve, it's some kind of nerve is coming inside this inflammatory process around the vein, and the time is needed to this vein to be resolved, to disappear. And after this time, when the vein is resolved and disappeared, the nerve is coming out from this inflammatory process, and all the symptoms disappear, and the patient feel a relief. And what is my opinion? There is two points, two issues in this question, because if we are coming from the distal part of the reflux below the knee, there is a very good study that showed that if you are trying to assess the vein at the distal point of the reflux, you will have a better VCSS points after the treatment. So you will have better results in the clinical point of view. And if you are not, if you are afraid of the nerve injury and in any case assess the vein upper the knee, in these situations the VCSS scores will be higher, the reduction will be lower, and the clinical results will be not so good. That's why, as for me, this nerve injury is not so important, and as Denise presented, it is not so important for the patients, and the quality of life is not suffering in such cases. That's why in my practice I always trying to assess at the distal part of the reflux, at the distal point. This is my comment.
Thank you. Your point, it was a very nice comment. Now may I ask Dr. Mohammed Al-Ma'adawi, do you have a comment or a question for any presentation? Unmute, Dr. Mohammed.
No, thank you for your efforts. Thank you for all your presentation.
Thank you, Dr. Mohammed. Now may I ask Dr. Trojaneski. Do you have a comment, Dr. Trojaneski?
Thank you. I don't have any questions. Everything was fine, pretty easy to understand.
Great, thank you, Roman. Dr. Omar, do you have a comment for any presentation? But not
yes.
mine. But
yes,
not mine.
It's about your presentation, the microwave ablation in Egypt. It was a great presentation, and you started to become connected with the first one to do a lot in Egypt. So I just want to ask you, what is the difficulty when you start first procedure, when you have two good golden standard worldwide like laser and radio frequency? Was it difficult to get it in Egyptian market, difficult to convince patients or convince hospital manager? What was the trip for you to be the first one to do microwave ablation in Egypt?
Thank you, Omar. It was a very great question. As a matter of fact, I started using microwave for the first time when I got a patient with a great vein with diameter about 16 millimeters. That persuaded me, if I do it in radio frequency or laser, I may get a less effective technique. So I heard and I know from Mark Whitley, I can use it up to 25 millimeter. That persuades me to use it in the first case, but it was very difficult to convince the patient this is a new technique and he doesn't know about it. He was preferring to use laser, and it was difficult to convince him, but I managed it. Now, are you satisfied by my answer?
Yes, yes. Thank you very much. But very great answer. Yes.
Thank you. Now I ask Sergey. No surgery already asked. I asked Dennis. Do you have a comment or?
Yes. I want to ask you, Ayman, about just two short questions. First is the price of the fiber for microwave in Egypt. So what is the price of the fiber? Is it comparable with the Venous laser, or is it cheaper or more expensive, or radio frequency? What is the price of the fiber in Egypt? And the second question, it's maybe a benefit of microwave. As I understood, these fibers don't have a part which can migrate to the lungs. Is it clear? Is it?
Yes.
So it could be a benefit, you know, because all of us afraid of this migration to lungs. So I have two questions: the price, and am I right with this construction of the fiber?
I know the fees of Professor Ayman are very high. It's a lot more than the laser, the fiber, and microwave combined. So you can answer the question now, Professor Ayman.
Thank you, Dennis, and thank you, Omar. The price of the laser fiber, microwave fiber, is a little bit cheaper than laser and radio frequency, a little bit cheaper. And yes, you got a point. This advantage, you can go as close to the femoral vein without the fear of damaging the femoral vein or inducing thrombus of the deep vein. It's much safer than laser, except you have to use a very good laser machine, and good laser fiber can do it, but it is much easier and safer in doing and using the microwave. Yes, you shorten the stump.
Yes. I was asking that, you know, on the top of the fiber of the Venous laser, we have a glass, you know, glass part, which can be damaged and migrate to the lungs.
Yes.
In microwave fiber, do you have this?
No.
So you have, so it's like a complete fiber. Okay.
Yes.
Oh.
It is not easy to be break either. It is more malleable, can manage to without fear of interrupting the laser beam. It is more malleable. Now I think
Excuse me, Dr.
I have done. Yes, please.
Sorry for the interruption, but I can't agree less with Dr. Omar and all the Egyptian phlebologists that you are one of the pioneers in the field of phlebology and the key players of this. I'm interested in microwave, but I want to ask you about the parameters that you use, because as you know, there is worldwide no fixed parameters like laser and like radio frequency to manipulate the machine. So what's your recommendation about the parameters we can use to update the vein?
Great. We have 4 parameters. Number 1, the temperature.
Yes.
You have to fix the temperature between 60 and 65. Number 2, the rate of withdrawal. We have to use 3 to 4 centimeter per half a minute. Number 3, the diameter of the vein. You can accommodate up to 25 millimeter vein. Number 4, the time. The time for each session of ablation, it varies from 5 to 15 seconds according to the diameter of the vein. All of this automated. You can put the program on the machine and do it.
Okay, thank you.
The 4 main parameters for echo machine. I think I have done for the panelists. Now the mic is with you, Omar, to ask or if the attendees have more questions.
Okay, I will take some question from the attendee to the last presenter, Professor Dennis Bursk. There is a question from Dr. Haydar Aslan. He practiced in Turkey. Using radio frequency is limited to up to 12 millimeter dilated great sufferance vein with the monopolar radio frequency. Is effective in dilated veins up to 20 millimeters. So I would just rephrase this question. He said that radio frequency can be used up to 20 millimeter. And this is a question to Dennis first for radio frequency ablation.
You know, we have here a pioneer of radio frequency, Dr. Sergei Belentsov. He is a pioneer of radio frequency in Russia. So I think that he ablated the biggest veins, you know, here, because in Russia we have very big experience of huge veins. But, you know, I have also a study. I showed it in Brazil and won the first prize there. It was our experience of treating of veins more than 2 centimeters of diameter with a laser. So I think that both of this method with radial emission, so it's a closure fast or laser with radial fibers, so you can achieve very good results with veins more than 2 centimeters, because, you know, in Russia we have far distance between cities, and a lot of people can come to our cities from Siberia or, you know, from far distance with very complicated advanced stages with big veins. And nowadays we can treat all of them with radio frequency of laser, never mind. So I think that the diameter is not, it's not a reason to do some open surgery nowadays.
Okay. Do you like to add a comment, Professor Sergi? Do you like to unmute? Yes.
Yes, yes. Our own experience is more than 2 centimeters diameter. We measure the diameter when patient is standing, but when we treat him, we have supine position. And after tube-stent anesthesia, the diameter become very small. So big diameter is not a problem for us in reasonable limits. For example, 25 or 27 millimeters, it is not a problem for radio frequency and for laser, in my opinion.
And is there a difference between monopolar and bipolar radio frequency? Does there is any clinical differences?
We use radio frequency of American producer, Medtronic, only this kind of radio frequency ablation. And so we don't have experience with another kind of models.
Okay. So the mic is back to you, Professor Ayman.
Thank you, dear Professor Omar. Now I think we came very close to the end of our session. I will ask Professor Shaydakov to conclude our session today. Please, Professor Shaydakov.
Thank you very much, my dear friends, and thank you very much for fantastic presentation, for my opinion, and very good questions, very good discussion. And thanks a lot for Covidian, which help us to organize this first forum. What we see, in fact, we have many tools today to accurately evaluate and properly treat patients with venous disorders. We have a universally recognized system to name everything and symptom of venous disease. CAP, Venous Clinical Security Score, several vein-specific questionnaires are very important instruments that help specialists from all over the world to speak the same language of venous medicine, of course. And by the the way the truth is often beyond our cognition. But who knows, maybe the freedom of choice is the matter of treatment is actually of strength. We don't know yet. So again, congratulations for all speakers and thank you, Sigvaris company. See you soon and continue our discussion maybe in the nearest future, maybe in St. Petersburg Venous Forum in the beginning of December. I invite all of you. Thank you very much.
Thank you, Professor Shaidakov. Sure, we would like to join you in St. Petersburg. It will be a great honor. Before I go, I would like to thank Sigvaris company and our great partner, prime partners for organizing this great webinar. And I will congratulate my dear friends. I will, excuse me, I will call it by first name because now we are more friendly. Thank you, Alexei. Thank you, Kurt. Thank you, Roman. Thank you, Alina. Thank you, Sergey. And thank you, Dennis. Thank you all. Thank you, Muhammad Al-Mabdawi. Thank you, Omar Farouk. Thank you, Khalid. Thank you, Amr. Thank you, Ahmed. Thank you all. I enjoyed your company. I thank all the attendees for joining us. Thank you, and I will say it in Arabic and Russian. Shukran and спасибо.
Спасибо.
Спасибо, yeah.
Shukran.
Shukran, and have a good evening. See you later.
Bye.
Bye. See you later.